Welcome, everyone. My name's Anthony Nappi. Just reintroduce our program for just a second here. I'm the nurse liaison for the Virginia Impact Project. Impact stands for Infection Mitigation, Prevention, and Control through Technology. And today we have Dr. Talia Pollok talking about the functional implications of long COVID or post-COVID conditions. And this is kind of a follow-up to our January session, which was with Dr. Kyle Enfield on the medical implications of long COVID. And kind of helps me think about where this fits in, where post-viral or post-COVID, but post-viral syndromes and particularly post-COVID fits into the infection mitigation, prevention, and control kind of theme is something that Dr. Enfield mentioned was you can't get long COVID if you don't get COVID. So it brings to light kind of the importance of prevention and vaccinations and that kind of thing. Reminder of our program, Virginia Impact. This is a primary focus is bringing together people across congregate settings. And also, so in this fashion, but also another focus of our program is on-site, in-person telehealth optimization in congregate care communities across the state. So you receive emails from me if there's any situation in which you might think we could do a little bit better with our telehealth, or we'd like to get some ideas or someone else to look at this, some fresh eyes to look at our telehealth program. We're always happy to hear from folks, so you can feel free to email me. Our price is right. We're funded by Virginia Department of Health, so we're totally free with respect to that kind of intervention. So that's my my shameless plug. I'll now introduce our medical director, Dr. Laurie Archibald-Pannoni, and we'll get started. Thank you.
Great, Anthony. Thanks so much. So good afternoon, everyone. Thanks for joining us. Very excited for our discussion today. I know that I have a lot to learn in this realm, and so I'm really excited to hear from our speaker, Dr. Pollok. So Dr. Pollok is a board-certified clinical specialist in cardiovascular and pulmonary physical therapy, working as a senior clinician in various roles throughout UVA Health. Dr. Pollok's clinical practice is focused on the unique needs of critically ill patients with complex cardiovascular and pulmonary conditions. Most recently, she restructured the UVA Health Pulmonary Rehab Program and created a new role for physical therapists within the post-ICU, post-COVID clinic. In May, she'll join with a small group of physical therapists from around the country to represent the profession and the interests of people living with long COVID during a long COVID summit with the Department of Health and Human Services in Alexandria, Virginia. So we're very excited to have Dr. Pollok join us today to speak about the functional implications of post-COVID conditions. So thanks so much for joining us.
Thank you, Dr. Pannoni, and thank you, Anthony, for having me, in addition to Dr. Enfield, to talk a little bit about what we do and what we see, and probably what we're all seeing. I think this is pretty timely. I think we focus certainly appropriately a lot on infection mitigation, disease management, certainly in the beginning of all of this, and now that we are, I mean, it feels like it was yesterday a little bit, but I guess we're a little bit of time out now. There's a lot of implications that are just sort of coming to light for a lot of patients. People may have survived, but they may not be thriving. So this is kind of where rehabilitation and other interventions can hopefully come in handy and help people sort of get back to living in some fashion that's meaningful to them. So let's see, now my slides won't advance. There we go. So I don't have any disclosures to report. Again, I'm just a clinician here at the health system. I've been here for on and off for a long time. Most of my practice was in the intensive care unit. Initially, patients with mechanical support, including ECMO, and all manner of whatever mechanical support we can provide people, and into the outpatient space and pulmonary rehab, and then now into the post-COVID clinic. So I kind of dabble in a little bit of everything, and have certainly had the privilege of seeing patients from the beginning of their hospitalization during a COVID infection, and then perhaps getting them to lung transplant and then getting them through lung transplant and then back to the outpatient clinic and seeing patients who were not hospitalized at all. So I feel very fortunate to have that perspective, to kind of have been able to see sort of the trajectory of a lot of different patients. So in terms of what the rehab role is in infectious disease, certainly we have a role while patients are in the acute care setting, in the acute care hospital, but then really I think a lot of the work happens when folks are discharged either into a rehabilitation setting, potentially home, which is what we hope. That's certainly what we had to do during the pandemic. There were really not a lot of places that could accept all of these patients. So we did do the best we could there, but certainly identifying patients who have perhaps been hospitalized or in the intensive care unit, and picking up on potentially their ICU or hospital acquired weakness that could then potentially lead into a post-intensive care syndrome, kind of allows us more of an active role in the restoration of physical, mental, and the emotional quality of life in survivors of infectious disease. And then we'll sort of talk about the other arm of that for patients who weren't hospitalized, but who are still suffering some very debilitating symptoms that really don't allow them the quality of life that they would certainly prefer. So when we think about post-acute sequelae of COVID-19, I mean, we hear a lot of terms: long COVID, post-COVID, past, all of this. It's really sort of it encompasses a lot of different things. We have, a post-intensive care syndrome or phenotype. We have patients with post-viral fatigue. We have patients who've suffered some end organ damage, and then patients who have unfortunately, have some other systemic issues because of the treatments that they have received. And most of the time, these are people who have had COVID or either a confirmed case or a probable case of COVID. We have symptoms that sort of last at least 3 months after the onset, 2 to 3 months after the onset, and otherwise just can't be explained by any other diagnosis. We don't really have always have a test for that, but these symptoms still persist. So in terms of a post-intensive care syndrome, which you can probably see a bit, certainly more perhaps in a congregate environment, whether it be a skilled nursing environment or a rehabilitation hospital environment, it's a constellation of new or worsening impairments physically, cognitively, or mentally that people tend to suffer after a critical illness, and or I think honestly just a lengthy hospitalization in general. And the term was really created so that we would be aware and screen patients for these particular impairments, because again, we focus so much on, appropriately so, focus on survival of a critical illness or an illness in general. But after the fact, when people are discharged from our care, whatever level of care it is, there may certainly be some persistent issues that don't allow these people to potentially return to work or return to their previous functional capacity, and that really needs to be addressed. And often those patients get lost, so we want to be able to identify them and then treat them appropriately. So this was from the Society of Critical Care Medicine. These are just some quotes from patients who, you see this woman here, she's ventilated, but she's like texting, and she's been in the hospital for a while. So at least she's kind of able to communicate, but some folks are just not really that active. And if we're not active and stimulating patients, then it's very possible that we're going to suffer a lot of, muscle weakness, ICU delirium. It's really going to affect, physically, mentally, and cognitively in a way that patients' families and these patients tend to suffer for quite some time. So I think a lot of people end up with a sort of a post-traumatic stress disorder as well. And what we can do with early mobility, with physical therapy, occupational therapy, and speech therapy, if we can get in to see these patients really, really early on in their hospital course, we can try to facilitate some regularity in their day, and make people feel a little bit more like a human being, have a little bit more control and say over kind of how they engage in the day. So that's really what we try to do to avoid, some of the quotes that you see here, some of these scenarios. So here's kind of the big picture from the Society of Critical Care. This is kind of what post-intensive care syndrome looks like for patients and for their families, caregivers, loved ones, et cetera. So the patient certainly can suffer anxiety, depression, again, like I said, post-traumatic stress, just the stress of being hospitalized and really not having a lot of control over what's happening. Certainly cognitive impairment, certainly those patients who have had prolonged mechanical ventilation or really high oxygen requirements, a lot of high flow oxygen requirements. We see a lot of deficit in executive function, memory, and attention just because of poor oxygenation, poor sleep, etc. And then certainly, the physical impairments we see, neuromuscular issues, we have lack of pulmonary recruitment, diaphragmatic weakness, overall muscle weakness, and you put all of those things together, and people leave the hospital, but they really just can't engage in a way that's meaningful to them. And then on the other end of it, you have, family, caregivers, partners who are kind of watching their family member, the loved one, go through this really intense experience. And they themselves begin to appropriately suffer a lot of the same issues, certainly from a mental health standpoint. And so they can't quite engage in their lives either. So it's sort of a perfect storm of impairments really for everyone. So when we talk about ICU acquired weakness, what does that actually mean? Well, this has actually been studied. This has been studied, for the last decade, and this is really what made early mobility kind of put it back on the map. I mean, I'm sure a lot of people have been mobilizing patients in the ICU for 30 years. It's just we didn't have a way to objectively study it and capture it yet. Now we do, and now we have a huge body of literature that not only supports this objectively identifying the symptoms of a post-intensive care syndrome, but we also now know the benefits of early mobility in a critical care setting or in a hospital setting. So we can define ICU acquired weakness as a clinically detectable muscle weakness in critically ill patients and hospitalized patients in the absence of weakness caused by any other factors. So somebody just comes in with, ARDS, and there's really no other neuromuscular issue that can be identified, but after several days of mechanical ventilation, perhaps neuromuscular paralytics, et cetera, people just cannot actively really participate in things like bed mobility, with the nursing staff for hygiene purposes or repositioning, et cetera. That's an ICU acquired weakness. There's really no other reason for that. We see a lot of muscle atrophy and wasting just within the first 24 hours of being mechanically ventilated, being certainly having some neuromuscular blockade on board will sort of hasten that process as well. We can end up with myopathies, we can end up with a polyneuropathy, or really, like, generally what we see is a little bit of all of the above. And again, this is just because folks are, require bed rest and the need for mechanical ventilation. Now we can kind of play with that bed rest a little bit, and if the oxygen requirements are such that patients can be awake and they can be engaged to a degree, then we're going to try to mitigate some of that bed rest to again mitigate the muscle weakness and the myopathies that we see. And when we do identify this ICU acquired weakness, and when you just know it when you see it. I mean, there are objective ways to measure it, but just as a clinician who's not a researcher at this point, I can just say that, and we all know it. We all know it when we see it. And it makes a lot of sense that, certainly that level of weakness is associated with a higher 1-year mortality, impaired physical function when we look at functional tests, and poor health related quality of life when we measure it. So again, the risk factors for developing an ICU acquired weakness, greater than 48 hours of mechanical ventilation. You could also add like mechanical circulatory support to that, any device that we have where people are sleepy and they're not moving. Then you, again, if there's a sepsis on top of that and a multi-system organ failure, sort of that persistent high level inflammatory response that we get certainly during COVID, and then sort of that low level inflammatory response doesn't really help the situation either. So, when you're looking back through a patient history and you see that, they were either admitted to the ICU and or had a fairly high oxygen requirement, that they're not, folks aren't going to be as mobile or engaged potentially. So because this is what I do every day and because it's what I love to do every day, this is kind of what we try to do to prevent ICU acquired weakness. We will work in teams of people, the nursing staff, our ECMO staff, our respiratory therapists. I mean, it's a whole soul train of people to put together to make sure that these patients are safely upright and mobile. The woman you see on the, and these are not UVA patients. These are just sort of stock photos, but this is a very good representation of what we try to do here at UVA, and certainly a lot of my colleagues and things across the country. Ambulating a mechanically ventilated patient. She looks really good and young. I don't know that she has ARDS, but she looks pretty good. Using this bed in the center, this is a bed that actually stands the patients upright. So you can get some weight bearing through the upper extremities. You can get some offloading of the posterior portion of the lungs so that, those alveoli can kind of pop open and do what they do. And progressively, you can even walk a patient off the edge of this bed. We do this now with our patients who have intra-aortic balloon pumps via a femoral cannulation, as well as our ECMO patients who also have femoral cannulations, and any other sort of configuration of mechanical support. So this is really helpful. And then you see the patient on the right. This is a patient ambulating who has ECMO, which looks to be cannulated. It could be a VV ECMO, I believe, that's cannulated not in the femoral area. So this is how we try to prevent it. But again, during the really more severe cases of COVID, patients were paralyzed, they were sedated. So a lot of this wasn't an option, but we tried to get to this as soon as we could. When it was safe to do so. So as rehabilitation professionals, this is kind of what we look at in our physical exam. We're going to look at pulmonary function, muscle strength, exercise capacity, gait speed, the capacity to perform ADLs, IADLs, balance. We'll talk about driving and return to work. This is what we want to look at to try to then screen for the presence and or absence of, of PICS or an ICU acquired syndrome or post-hospital syndrome. And all of the outcome measures you see on the right, again, these are, this is what's cited in the literature. This is what we would typically use. Now in the hospital, sometimes these aren't as practical to use. A 6-minute walk test may not be something we can use, so we have other means to do that. But in terms of transitioning into either a skilled setting or another rehab setting, these are all things that are available to clinicians to use, and they're all free. They're all open source, and I highly recommend. And they all have, normative values for different patient populations, and that's all available, again, in open source. So what's cited in the literature for identifying an ICU acquired weakness is using the MRC sum scale, which is basically just a test of isometric strength in the upper and lower extremity, like using a dynamometer. I can tell you that this is great for research purposes. I don't use this as a clinician. We certainly do a gross screen of strength, just like you might perform your neuro exam on a patient, looking at range of motion, looking at strength and grading that strength from like a 0 to a 5 out of 5. And then really what we're doing is we're going to look more at functional mobility, but there is certainly a really good application here of isometric strength testing, and that can give you a window into function, but it doesn't actually show you function. But for the sake of this talk and the fact that we're just talking about, ICU acquired weakness and how it is objectively measured in the literature, I felt obligated to include this. So does strength actually equal function? Well, yeah, it can. I think that it just sort of depends on how you're going to assess it. So if you're looking, again, if your patient's in the bed or they're sitting in the chair and you're going to do sort of a gross isometric strength assessment, that's great. That's absolutely better than nothing. And I think with time and experience, you can kind of extrapolate out how a patient does during that particular gross motor screen versus doing, a more functional test like we'll talk about in a moment. So a functional test, like watching a patient stand up, what they say, the eyeball test of can the patient get out of the chair and get up onto your exam table in your outpatient kind of office. That's the eyeball test. We have other objective ways to look at that, but it can really give us, those functional tests can give us a really nice window into the level of assistance that a patient's going to need for their mobility and their ADLs. Do we need to look at assistive devices? Are we going to be able to safely access a home environment? Or, does the patient have to climb stairs? Is there a ramp? Kind of what are the implications there? We can look at fall risk, and then a lot of our functional tests that we see or that we use will give us a window into like an overall mortality and how a patient might utilize their healthcare dollars, kind of marching it out a bit. So really what I think, and Anthony, you can chime in here too, you do this a lot. If we look at explosive strength and power, and I know we don't normally like associate explosive strength and power with critically ill patients, hospitalized patients, or post-hospitalized patients, but that's really what it is we're looking at when people stand up from a chair, they stand up and walk, and then we look at how quickly they're walking. So how do we objectively capture explosive strength and power? We look at, as rehabilitation clinicians, we'll look at how long it takes a patient to perform a sit to stand transition 5 times. So you really want to see how fast can a patient do that, do 5 repetitions of sit to stand. So that measures an explosive strength, not just, regular isometric strength is like how is that strength being applied to movement. So if it takes a patient longer than 12 seconds to sit and stand from a chair, that translates into a higher fall risk. We can look at a timed up and go test, which is sort of the next evolution of a stand test. You stand up, you walk 8 meters as fast as you can, flip a little U-turn and come on back. And again, that's another indicator of explosive strength and fall risk, dynamic balance, things of that sort. And then you look at gait speed, how fast can your patient or client ambulate a particular distance? There are different distances you can do, but we know that patients who walk a bit slower because of weakness, balance deficits, limited cardiovascular or pulmonary function, we know that those patients are a little bit more, or they're higher risk for falls, and their frailty is overall a bit higher as well. So these are just things that. Oh yeah, go ahead. Sorry.
Just to pipe in. So I look at gait speed all the time, just as a person walking around town when I watch people cross the street and that kind of thing. It's one of my interests. When I think of, someone working in a facility, maybe it's an adult day center or it's a PACE center or a skilled nursing facility, someone who's not trained as a physical therapist, what would they look for? And those kinds of things that I talk to people about are like, how does the person get up? You likely know this person for a while. How does the person get up from the toilet? Or how does the person get up from bed where they really do have to use power? Or how are they walking down the hallway compared to what I knew before the hospitalization kind of thing? As I try to talk to people about that, as far as just kind of a lay, maybe not quite a lay person, but a non rehab specialist's view of power and strength and gait speed and that kind of thing. So yeah, I'm always geeking out and looking at this stuff and looking at gait speed, and at the same time trying to think about what does this look like in just a normal scenario where you're not, expressly trying to assess the person, someone who's not a rehab specialist. But yeah.
No, absolutely. And that makes a lot of sense. And I think just watching people's compound movements throughout the day, again, like you said, especially if you know them and you go and you say, huh, that looks a little different. Folks don't look as steady. Maybe we're a little bit shorter of breath. Gosh, that person's really moving slow. What can I do, until, if rehab is not available or not involved or whatever, what do I need to do as the bedside clinician or the nurse, the PCA, the physician, how can we make this a little bit safer? And, these people, your spidey senses are going to be, on point, for lack of a better expression, to intervene when you need to. We don't need these objective tests to do it. We use them because it's a great way to quantify things. Insurance companies really like it. And, we can prescribe exercise, based on what we see here and then retest, right? But if you're in, if you're into your sort of everyday environment, you can look at movements like this and kind of extrapolate out, well, gee, functionally, I'm seeing kind of a decline here, and how can we intervene to make this person a bit safer? And just by the way, like these people in these pictures are doing squats with kettlebells and things. We absolutely do this with our patients, inpatient as well as in pulmonary rehab. We just give them a little bit more oxygen and they go, because this translates into function in their daily lives. I can't just leave them on a new step or put them on a treadmill and hope for the best. So we have to get a little bit creative when we're assessing this to a degree and then treating it from a rehab standpoint. So all this stuff is safe to do. You just have to kind of dole it out appropriately. It's exercise like any other medication. Or any other intervention. You need the right amount at the right time for this particular person. So I just a plug. This is actually stuff that we would do. And it's safe, I promise. The other big thing we really need to look for in these patients, and again, if these are patients that you've known for a long time, they've done rehab with you before, they're a resident at your facility, they go to the hospital, they come back, and you think that things are just not computing as well as they used to, you can certainly screen for that. We have tools for that. Again, looking at cognition, we can use a MOCA. Occupational therapists use this a lot more, I think, than PTs use this. And that's just sort of a quickie screening tool. It doesn't really pick up on very specific cognitive issues, but it will alert you to issues with memory and executive function so that patients can then undergo some more more specific testing. Certainly, we give patients in the post-ICU clinic, we'll screen for depression and anxiety, and physicians talk about medication management for that quite a bit. We'll refer patients to local mental health professionals, back to their PCP for management of that medication. So we'll often refer patients to our neuropsych department here at UVA too, if we're seeing a lot of these impairments together. And then certainly, like I had said before, being hospitalized, particularly in the ICU, is a traumatic event for a lot of people and their families. So being aware of that and looking for that is important so that we can get people to the right professionals to help them work through it. So certainly for a post-ICU patient, our intervention strategies are going to be getting them into our clinic. We're a small clinic. There are bigger ones, we're smaller, but we do the best we can in helping with, certainly medication management, following up on any systemic issues, repeat imaging, repeat testing, things of that sort. But then from a rehabilitation and supportive care standpoint, we want to look at where patients are based on, a really good history and just chatting, based on the objective tests that we talked about, that we use in our practice. And we look at, how can we facilitate some independence for people so that they feel like a human? Do we need an assistive device? Do we need some other adaptive equipment? Do we need to talk about pacing and energy conservation strategies? And can we get them on an exercise program, whether it's in the community with a community provider, and a local YMCA or a fitness, institution or place, gym. What programs do we have in the community that would fit a patient's particular needs? And then just talking to patients and their family, and debriefing with them about their experience. And there is a name for some of the symptoms that they're experiencing, and providing resources. There are a lot of resources through the Society of Critical Care Medicine for families and patients who have been hospitalized. And then certainly the restorative strategies, focused rehabilitation. We can do a lot of really cool, fun, creative things with patients, help get them engaged, and really kind of try to figure out what it is that patients enjoy doing and try to recreate that in a rehab environment, and build on that. So we're doing task specific rehabilitation versus just like, kind of cookie cutter stuff, which is boring actually for me, and it's really boring for patients. And then again, just coordination of your resources. Know your community resources, your mental health professionals, your driving experts in the community. OTs do a lot of that. Neurocognitive rehab. Just know what you have available to you and refer appropriately. That's the sort of post-hospital, post-ICU portion of this. Does anybody have any questions or thoughts or something that I didn't quite hit on that you want to address at this point? No? Okay. Everybody needs to stand up and do a stretch. Go for it. This is the time. So now we'll sort of transition from that post-hospital patient, post-ICU patient into our patients who were generally not hospitalized, who may not have all of the comorbidities that we're so used to hearing about being associated with a more severe infection. These are our long COVID patients, our long haul patients. There's a lot of different names for that. So again, sort of same sort of setup. History of probable or confirmed COVID, usually 3 months from the onset. You have symptoms that last for 2 months, and there's just really no other explanation. And this was kind of an interesting slide, just sort of giving a very large systemic overview of, kind of what we're seeing in terms of symptoms and kind of where they're coming from. So it's a whole lot of everything. So this is an interesting slide. So this is from, I think there's about like 600 patients between 3 different institutions who had post-COVID. They had lingering symptoms 3 to 4 months after their infection, and they were surveyed in terms of which symptoms they experienced at any point in their illness. And almost all of these patients, certainly you can see the constitutional symptoms there, but pretty much everyone reported fatigue and a post-exertional malaise, which we'll talk about in just a moment, because the post-exertional malaise is really a key feature. It's a key symptom in certainly how we would proceed with rehab management of these folks. So again, this is just, you have a bunch. I think there are over like 200 symptoms, 200 to 220 long COVID symptoms. And that's really intimidating for those of us taking care of these patients. And it's super intimidating for patients. So generally what happens is these patients go through all of the workup. We look for cardiac impairment. We're certainly doing CTs of the lungs and PFTs. We're looking at everything to try to rule out what I'd like to call the big, nefarious, nasty stuff that could cause some of these symptoms. Again, see a lot of patients with GI disturbance, especially our patients with dysautonomia. And certainly, I would say 90% of the patients we see have disordered sleep, fatigue, and some sort of cognitive impairment. Now, why that is, again, there are lots of hypotheses as to why, people have these lingering symptoms without, a positive, test in some capacity, but we're still everybody is still working on it. So again, this is a paper that came, I think this was last year. This was Nature, and this was a really, really nice paper that sort of summarized, kind of what do we know so far? Not a lot, but a little bit more than we did before, and kind of where are we going to go moving forward. So again, just looking at some potential mechanisms of why people have these funky lingering symptoms. Do we have an immune dysregulation? Do we have like a super big immune response to COVID? Folks who have had latent Epstein-Barr, other viral things beforehand, did we get sort of a reactivation of that infection, which then caused, this low level inflammatory response? What's going on in the microbiome? That's a very, very interesting area that folks are looking at. Certainly, autoimmune response, people getting sort of a really large immune response. Certainly, the small clotting, I think that's still being investigated, but we still don't know a lot about that. We can't really find these microclots in people, or are we just having a dysfunctional vagal nerve kind of response? I mean, the way that I explain some of this to patients is that, for whatever reason, this virus, your body has responded in a way that, your normal body systems, your autonomic regulation is not regulated anymore. The virus has hacked your body's ability to, kind of pass those messages neurologically or regulate yourself neurologically. We don't know how and we don't know why, but that's what it seems like is happening here. So this is what patients say. This is what a lot of people have said when they come in to talk to us. I can't stand up long enough to make a meal before my heart starts to race and I'm going to drop. My legs feel like lead, but all of my tests come back normal. My lungs are fine, my heart's fine, my brain is fine, my blood is fine. Like nobody understands, why I still feel this way. I'll have a really good day. I'll push it, but then I'm tired for like the next 3 or 4 days and I can't do anything. And I have seen a lot of really active people from the age of 18 to, 60 plus who've been super active, running races, exercising. I mean, one gentleman played he was in his 80s and he played the trumpet. And then, walking into my clinic was a problem. And, patients were just so tired. It was like they fell asleep one way. They had COVID, they fell asleep one way, and then they woke up and they were just not any version of themselves that they identified. And that's a huge, it's just a huge load to carry, for them. So the fatigue is, again, this is a hallmark symptom of some of this post-viral illness. It's this fatigue, this exhaustion that is way more than just being tired, and it's usually not fixed with sleep. Oftentimes, what people will say again is that, if I'm mentally engaged in a task or I'm physically engaged in a task, it takes me longer than 24 to 72 hours to recover. Generally speaking, in a quote normal state, if you have a pretty busy day at work, you have a pretty busy day doing whatever it is that you're doing, you can maybe get a good amount of sleep, and then you're pretty much back to your baseline the next day. You might be a little tired, but you can pretty much continue on with what you're trying to do. These patients can't do that. That's sort of the hallmark symptom of post-exertional malaise, post-exertional symptom exacerbation. And we know that challenging patients and encouraging them to exercise is not going to make this better, because this is not cardiovascular deconditioning as an etiology of fatigue. This is a post-viral process, potentially something within the body's energy system. That's kind of what the working hypothesis is there's something going on with mitochondrial dysfunction where patients just they are unable to create the energy that they need to kind of move on within that 24-hour period. So I have some colleagues at the Workwell Foundation in California. It's out of the University of the Pacifica. It's a physical therapist and exercise scientist. Kind of put some words to post-exertional symptoms and post-exertional malaise, and sort of gave us a playbook on what to do for these patients, and more importantly, as rehabilitation people, what not to do. So, in the immediate post-exertional state, people might be tired, out of breath, potentially nauseated and dizzy if they have some autonomic dysfunction. That can last for a couple of days. People may feel a lot of musculoskeletal pain. They may feel a little bit cognitively slower, and certainly sleep is always a problem. Unrefreshing sleep. People may get to sleep, they may not stay asleep, or they may not feel rested when they wake up. Any post-exertional symptoms that last a little longer than a week, it's going to feel kind of like the flu again. So what we have to do is we have to help people figure out what their triggers are, manage their energy levels throughout the day if they're able, and then when we can do that, slowly reintroduce exercise so that we don't end up with post-viral fatigue and cardiovascular deconditioning. So this is kind of like the really hard part about managing folks. This is one of the harder parts. So we know that, cardiopulmonary exercise testing, that's kind of the gold standard of assessing a patient's cardiovascular and pulmonary function fitness. And we've done this in all of these different patient populations. Deconditioned patients, patients with heart failure, cystic fibrosis, all of the things. If you were to do a cardiopulmonary exercise test on a patient, maybe with heart failure, on one day, you're gonna see pathology there. But if you were to test them the next day, they would definitely repeat their test results. They should look almost the same. What's interesting is in patients who've screened in for post-exertional fatigue, they have chronic fatigue syndrome or maybe myalgic encephalomyelitis, and they meet the clinical criteria for those things. If we do a 2-day cardiopulmonary exercise test, these patients perform worse the second day. Most deconditioned patients or patients with any of the systemic issues or disease processes that you see here, they may not perform well the first day, but they will perform the same the second day. And our patients with post-viral fatigue, they reach their ventilatory anaerobic threshold earlier, so they just have less oxygen and less energy circulating than they did, or for available for use than they did the day before. They probably didn't perform well the first day, but they really don't perform well the second day. So that's a really that's like the one objective measure we have for post-viral syndrome. But like the feasibility of a 2-day cardiopulmonary exercise test, I mean, it's just not a very practical thing to do unless you're in more of a research environment. So instead of putting everybody through a 2-day CPET, we have some screening questions that we use. And, if you can get a CPET, great. But most of the time, patients don't have access to that. I just went through that, sorry. Okay, so this is kind of what happens in my head when a patient is referred to me or to our clinic with COVID listed on their primary diagnosis. So I need to figure out, how am I going to rehab this patient? Is this a patient who has been hospitalized and they have some, certainly they have some interstitial disease, interstitial lung disease? Are they more of a pulmonary rehab patient that's going to be appropriate for like a graded exercise approach? Or do I have a patient who has a post-viral fatigue, who's not going to really respond to exercise in the way that we would all want them to, that we think that they, quote, should? Do I need to focus more on pacing, energy conservation, using heart rate parameters to keep them in what we call an energy envelope so they don't overexert? I'm not going to be able to exercise that person in the same way that I would exercise a patient who does not have post-viral fatigue, who may just be our sort of regular post-hospital type patient. So I'm going to screen for all these things. I'm going to look for joint hypermobility because we know that some patients with connective tissue disorders are more susceptible to post-viral fatigue and dysautonomia. So I'm going to screen for that, and there's an objective measure for that. I'm going to screen for post-exertional malaise or post-viral fatigue. If that's present, I'm going to focus more on pacing and energy conservation versus exercise because that's going to make the patient feel worse. I am then going to screen for dysautonomia. A lot of these patients have POTS or some bit of orthostatic intolerance. Where it gets tricky is when patients have an orthostatic intolerance on top of a post-viral fatigue, because those management strategies are pretty much the opposite. Patients with dysautonomia typically do really well with graded exercise in a recumbent position, but if they have post-viral fatigue, I can't exercise them right away. So we have to look at supportive management and symptom management. This is an ACC expert consensus decision pathway on treating patients who have cardiovascular symptoms, after COVID. And so if you're suspecting orthostatic intolerance in your patients, certainly, as rehab professionals, we can do this, and anyone can do this. We can look at orthostatic vital signs and really having the patient stand for about 10 minutes. If you don't have access to a tilt table test, you can have a patient stand for 10 minutes and you can look at heart rate and blood pressure on standing, and you can assess symptoms and look at the heart rate response and blood pressure response. Again, we don't have a tilt table test here at UVA. We don't have autonomic testing here. So between cardiology and ourselves, we do the best we can. And if somebody is really involved, we'll refer to a bigger center. I hope that will change at some point. So for POTS diagnostic criteria, you really need a sustained heart rate of greater than 30 beats a minute and a significant amount of orthostatic hypotension. Honestly, I haven't seen a lot of patients with POTS, but I've seen a lot of patients with orthostatic intolerance. They may not meet these criteria, but in terms of how we treat them with supportive measures, it's a lot of the treatment strategies are the same. And again, if we've ruled out things like any other cardiac etiology, hypovolemia, adrenal issues, medication issues, if we ruled all of that out, and most of the time, people have seen everyone before they come to us, that all has been ruled out. So we try to kind of figure out if there is an orthostatic intolerance component and how we can offer some supportive strategies there. So really, those supportive strategies, if it's appropriate, if patients have the blood pressure tolerance for it, we want folks to be drinking. We want folks to incorporate more sodium, more salt into their diet, a lot of electrolyte replacement. We can use compression garments. Really, most patients do really well with abdominal compression and lower extremity compression. If we have well-controlled post-exertional fatigue, or it's not present at all, there are very specific exercise protocols that these patients do really well with. So we want to increase their core strength. We want to increase and really just improve vascular tone throughout. And we usually do that through a lot of core exercise and then recumbent cardiovascular training. And then, there are certainly different medications if patients are, if again, their blood pressure can tolerate a little bit of propranolol or midodrine, that can be really helpful. But oftentimes, it's not a one size fits all scenario. You have to try different strategies. So in terms of objectively screening for these things, looking at post-exertional malaise, again, once you work with these patients a little bit, you'll know it when you hear it. But if we really want to try to capture it objectively so that we can test and then potentially retest, or if patients are filing for a short-term or long-term disability, we do need these instruments to kind of help us capture what's happening. We can use the DePaul symptom questionnaire. That's a really good one for post-viral fatigue. And then there are a few for dysautonomia. The Malmo-Potts symptom score is a new one. I like this one. It captures more orthostatic intolerance than it might actually capture POTS, because it really it's a little bit more sensitive, I think, to that. And if you have access to a tilt table test, great. If not, we can do a 10-minute stand test in the clinic. And then again, just looking at joint hypermobility to see if that is a potential issue, because again, if patients are hypermobile or they have a condition that may predispose them to post-viral fatigue and or dysautonomia, how we rehab them is going to be impacted by that as well. I also look quite a bit at breathing mechanics and breathing patterns. You might see a lot of patients who are just short of breath. They have dyspnea on exertion, but their SATs are fine and they have no structural issues in their lungs. So why are they not breathing well? So I have some additional training and just some breathing biomechanics and things of that sort. But essentially, it's just looking at the breathing pattern. Are patients able to take a low and slow breath into their rib cage and diaphragm, or are they really mouth breathing and using a lot of accessory muscles in the upper chest? We ask a lot about sleep, pain, certainly, looking at cognition, overall strength, coordination, and then if we can do a submaximal exercise test, that's great, we'll do it. But if folks screen in for post-viral fatigue, then I'm not going to put them through, a submaximal exercise test just yet. But this is just sort of additional bigger picture things that we like to look at. So we're trying to figure out where we can, what's the biggest bang for our buck? What symptoms can we help a patient manage in order for them to get a little bit of energy back, so that they can, engage in their day. And a lot of that we'll do with symptom journals. A lot of people have, some kind of a smartwatch or a Fitbit or something. So we'll look at heart rate monitoring. If they don't have that, I'll teach them how to do it so that we can figure out, what their body is doing when they are in a particular scenario where they're feeling unwell. So we can try to help them avoid that. So again, certainly if we have post-viral fatigue, my first job is not to exercise patients or tell them to go for a walk, they'll feel better. My job is to help them figure out how they can engage in their day using a little bit less energy. That might be, cognitive rest, taking a break from screens. It doesn't mean like go take a nap and put your feet up. That's not always what it means. It's just trying to incorporate some type of rest, whether it's emotional rest, cognitive rest, screen time rest, whatever, and sort of hitting the pause button really before they get tired. It's like pain control after a joint replacement. You just want to be ahead of that pain. So go ahead and take your medication before the PT comes in, rather than getting you to a 7 to 10 out of 10 pain and then trying to work backwards. Energy system management is really a lot the same way. We look at symptom journals quite a bit to try to figure out what activities or circumstances trigger patients into their post-viral state. And if we have heart rate biofeedback, that's even better. We refer to occupational therapy and neuropsychology quite a bit for those patients who continue to have persistent cognitive symptoms, brain fog, memory deficits, a lot of attention deficits. And mostly what I do in these visits, honestly, is a lot of education. People will report their symptoms to us. They have reported symptoms to their healthcare providers for a year, 2 years, or more sometimes. And we can finally give a name to what it is they're experiencing, give them evidence-based resources to go to and look at so that they, you kind of name it to claim it. And I mean, that is often more therapeutic sometimes than any sort of rehab we can give a patient. It's just people being heard and people being believed. It has really taken me back. I mean, every time people get very emotional, they cry a lot, and I get a little verklempt too. I mean, it's really incredible what these folks have been through in terms of being, they've not been heard, they've not been believed, and it's really very humbling. And I'm privileged to try to give them a little something to get a little bit of control back of their bodies, because people just generally feel out of control and quite hopeless. So if we can give them a little something right now until our research and medical communities can give us a little bit more in terms of therapeutics or treatments, then I'm more than honored to try to do that. So again, looking at pacing, projecting, and planning, again, this is a lot of the patient education that we do. And again, this is compliments of my friends at the Workwell Foundation. Really, really nice. And some of this may be intuitive to some people, and some people it may not be intuitive at all. And this is pacing your day out is a really privileged thing to be able to do. Some people just aren't able to do this. So if they're not able to do it, then what can we try to workshop and figure out to, if we can't do it in an ideal way, well what's the best way that, what's one thing you can do in your day to pace, project, and plan. So we talk about that a lot in our clinic. And sort of putting it all back together, these are some resources for our patients with long COVID, and then certainly our patients that are recovering from either critical illness or a prolonged hospitalization. After the ICU, the Thrive Initiative and ATS, a lot of great stuff for patients and their families. So if you encounter this in your clinical practice, I'd certainly recommend these resources. And I think that's it. Thank you all so much for your attention.
Thank you, Talia.
Yeah, thank you. That was wonderful. Certainly
Me
open
too.
up for questions from the group. We have a few moments. If anyone from the group has questions, feel free to unmute or to put into the chat. While we're waiting, I just wanted to say, thank you so much for that. I think that your point to ensuring that patients are heard, and when we, putting a name to their symptoms, especially after they've been through, so many different iterations of, well, just do more, or, whatever people are telling them. I think, being able to put a name to a syndrome is so powerful, and being able to get patients into the right space to be heard and then to be supported through their recovery is critically important. Do you have recommendations for, us as primary care providers, or, caring for folks over long-term in our rehab centers or congregate communities? How can we kind of get patients in the right place? I mean, obviously you guys do a phenomenal job. Your capacity is kind of limited. Are there other resources or recommendations, or how to kind of write an order to kind of ensure that the patients are getting to spaces where they'll be heard? These types of things.
Thank you so much, and thank you for asking that. I think this is really hard for primary care physicians and APPs to get through, because you have such a limited amount of time with patients, and this is just kind of yet another chronic thing that is put on your plate to manage. What I can say is that if your patients have gone through cardiology, neurology, if they've gone through all the people and all the things, the first thing that I would just really encourage is if fatigue is an issue, ask about the nature of that fatigue. Does it get better in 24 hours? If it doesn't, how long does it take you to feel better? That's a huge piece of it. If we can kind of figure that out, and again, there's no magic bullet for that. There's some, like Dr. Enfield talked about, there's some off-label use of some, medications for ADHD and things of that sort. But I think just understanding the nature of that fatigue, and understanding that, certainly these patients really want to feel better. They're not lazy, but it may be that, encouraging patients to exercise and do all the things that we know to be true for pretty much everyone else doesn't necessarily work here. So when you see those patients and you see, maybe seeing somebody in the community to help you manage your energy, to help you or exercise in a way that won't exacerbate your symptoms, that's how post-viral fatigue, post-exertional malaise, if you write that in your referral, I think that's a great place to start. What I have found is that, the rehab community has been, as other communities have been, a little skeptical of exercise isn't medicine. And so what we're trying to do from a professional association standpoint, either here at the state level and then nationally, is to really educate the rehab community in how to provide safe rehabilitation strategies. So even if a patient comes to them and maybe their primary care provider has not heard of post-viral fatigue or really understands how it should be managed, at least they can screen for that and then manage that appropriately and then communicate that back to you. But in terms of patients that you may be seeing in a congregate setting, you're just really looking at a lot of those patients. Honestly, I've not seen a post-viral fatigue in our hospitalized patients. There's some, but it's mostly patients who have really impaired pulmonary function, and it's really okay to challenge them physically as long as your rehab staff is monitoring vital signs. I mean, I know it seems like a really basic thing, but sometimes it just doesn't happen. So if we're looking at heart rate response, if we're looking at oxygen saturation, can your rehab professionals titrate oxygen for these patients? What does that policy look like in your facility? I had to talk to all of the pharmacy people at UVA to get privileges to titrate oxygen at pulmonary rehab. For patients with IPF, if I needed 10 liters, I needed 10 liters, and I needed to be able to do it. So it's okay, and it is safe to push these patients who seem a little fragile. The only way they're going to get better is to gently push them, but you have to do it in a safe, educated way. And honestly, it's super basic. It's just vital sign, monitoring, RPE scale, but don't be afraid to push them. They are much more capable and physically than you might think.
We're running a little tight on time, but there was one
Go
question
for
in the
it.
chat from Wendy, wondering if you had seen anything with respect to treatments related to ENT concerning maybe persistence of COVID in the sinuses.
I have not seen that. We do look a lot. I try to be really aware of any kind of nasal health and any kind of structural issues that would prevent a patient from breathing well. And if we do identify structural things, we will refer to ENT for that. But I have not seen that just yet. But I should probably look for it. Good point.
Well, thank you.
Have a
Thank
question.
you
was
all.
great.
Sorry to go over.
That's good.
Okay.
Very
It looks
informative.
like, well, for
Sorry.
anyone who needs to leave, feel free to. The code for the CE is listed there, but it does look like we have one more question.
Yes, I
Okay.
got a question real quick. So I'm an infection preventionist at long-term care, skill and rehab. And looking at this whole presentation, it looks like, if we happen to know beforehand that the resident who's coming in as a new admission had a COVID-19, I think it will be really beneficial. So that sometimes you get the admissions from home, admissions from hospital, admission from the other same kind of facility or skill facility. Do you think we should add this question in the infection control screening form? I think CDC or VDH declared this form, which has 3 pages, asking all these questions about immunization, asking about if they have any other UTI or any other kind of infection. Do you think we should add this question too? That did they have a COVID? Yes, then when?
Yes, I think that would be lovely. I think everyone should ask that question.
Okay.
Yes, no, I think that's yes, I think that could be very helpful. And just in terms of kind of what everybody can expect in terms of performance and function of this patient, and then perhaps how to proceed, as we rehab these folks in the setting that you're in, that would be a really nice piece of information to have as a therapist coming in to see that patient for the first time. Yes, that'd be great.
Thank you.
Mhm. Thank you all so much for having me. I appreciate it.
Thank you. Much appreciated. Excellent information. And we'll go from there. I will send out, for those still on, I'll send out a mass email over the next few days and include this slide as well with respect to claiming credit for CE.
Have a great
Fantastic.
rest of your day, everybody. Thank you so
Thank you.
much.
Thank you so much for joining us today. This is wonderful, very informative.
Bye-bye.